microorganisms. As you know, microorganisms is the core result of any infection in endodontics, directly or indirectly. So there is infection, there's bacteria, but it's chronic, it's asymptomatic in nature. But that's worse too. You have to intervene, because what happens if you don't? I've had patients who have been like, well, thanks for telling me, doc, but I really don't want to treat it right now. I'm just going to focus on the other side with my finances. And I tell them, okay, well, you have a choice to do nothing at this time. But I do want to share with you that it could be that on your progression, 6 months to a year, that lesion is going to continue to grow. And it may be asymptomatic. But what happens? It compromises the attachment apparatus. So you may risk the chance that you might lose that tooth. Okay? That's important for your dialogue. But since we're already going to be transitioning to treatment planning, I thought it's a good case to discuss. So retreatment would be a better option. Believe it or not, some patients have said, I'm not going to have you touch the crown, because you know what? I have to let the patient know that if I do a retreat, it could compromise the crown, given the fact that I have to extend my access, because now I'm trying to disassemble a previous case. So that requires me perhaps to increase my access cavity. It's not uncommon that I would tell the patient that it might need replacement of the crown. Most of them are pretty open to that and conducive to that. And some of them just like, no, I don't want to do that. I can tell them, okay, you can go the surgical route. All right. So another interesting case, right? Because it's number 31. Yes. So yes. Interesting this is. So yes, that's true, isn't it? So I got the same thing, right? So it comes to us for a referral. Okay, so this is one of my practices. I'm looking at it and I'm like, this is a really good crown, okay? And the post space is in alignment with the long axis of the root. I mean, they forgot to put the post in, right? Regardless, after a long time, as you can see, the lesion formed and it presented to us. We traced it with the sinus tract, so this becomes previously treated with chronic apical abscess. So what do? Retreat it, because obviously you have a good amount of undebrided, unobturated space. Okay. So go ahead and we retreat it. Oh, I didn't put the final fill in here. It came out. Yeah, so I apologize for that, but I'll hopefully get some time to share that case with you. But fast forward, it was a beautiful healing we had. So we finished the obturation and post-op within a year, completely healed. Okay. So always present a good option to the patient, because what is endodontics? It's an opportunity to save the tooth, right? Because there's no substitute for a natural tooth. So whether you do retreatment, you do surgery, there are a lot of options out there. So encourage your patients. Sometimes it's, they're demotivated. They're, well, I did root canal, I spent time on the crown, I don't want to do anything. I just want to take it out and put an implant just like I have on the other side. And I try to talk to them about it, and I share with them, and I share where you have excellent bone in this area, and you don't want to substitute a natural tooth like this. I would certainly attempt to do a retreat in this case. If anything, you would be preserving, from a financial standpoint, more on this than you would on an implant with a full coverage crown. Okay, so again, a little bit into the treatment plan. It's okay for you to say, I can't tell exactly what the problem is at this point. Let's put you on this pain medication and see if we can resolve this within 24 to 48 hours. Symptoms will tend to localize within 2 to 4 days, and you can pinpoint the correct tooth. And typically that happens when you do a cold test and you're just not sure which one it's. I think it's this one, but the patient is also like, yeah, I think it is, not really responding the way I do, and wakes me up in the night. So what does that mean? Maybe the pulp is dynamic. It's transiting from irreversible to necrosis or partial necrosis. For a pulp to be dynamic, it doesn't take more than 24 to 48 hours. It could be 2 weeks, could be 2 months. We don't know. But it could be in a transition and the patient now is confused. When 3 days back it was waking me up, I'm not too sure right now. Okay? Often 1 or 2 days will make a difficult diagnosis in case you're one. Interdisciplinary consultation to reach a consensus for a correct diagnosis is something that does happen, and it's encouraged. When in doubt, ask your team, well, especially in that case that we saw where it was non-odontogenic. Okay? All right. Treatment planning, always start with a good, accurate diagnosis. Secondly, okay, always have a complete diagnosis. A pulp and a periapical don't come with half a diagnosis. It's okay to say that, Dr. So-and-so, I'm not sure about my periapical. I'm a little confused here. I think it's symptomatic. I don't know if it's asymptomatic, just because the patient sometimes has symptoms. Okay, and that's okay. The other thing is sometimes the patient may say, oh, I don't even bite on that side, it hurts. And then you do percussion and there's no pain on percussion. You have to go with your test results. You note in your record that the patient has been not chewing from that side, but your diagnosis still today is not symptomatic because you were not able to replicate that symptom on that thing. Okay? So accurate diagnosis, a complete diagnosis, which is a pulp and a peripheral diagnosis. Determine case complexity at the same time. Is it a complex case? Is it complex anatomy? Is it second molars or automatic referrals to endo residents? Determine the prognosis. That's also key to your treatment planning. Prognosis in endodontics is favorable, questionable, or unfavorable. It is not good, fair, and poor. Okay? Determine the restorative plan. Restorability must be determined before definitive treatment is initiated. So that's important, right? So if you have a case, like we saw some of these cases which had deep carious lesions, right? You don't want to be in the rush to be like, okay, well, let's do endo. I always tell the patient, well, you take a bite ring and you still think it's pretty expensive. I let the patient know that we're going to go ahead and do caries removal. But it could be that we go deeper than what we think, and we have to determine restorability. And then if we determine it is restorable, we have to determine if you need to do crown lengthening. And that's a separate procedure and a separate financial add-on to this plan. Okay, so that's important to know, because if you don't share that with the patient might just be like, well, I thought you just told me I need a root canal. Now you're telling me I need to do crown lengthening. This may need a crown. This may need a post. I'm not sure I'm ready for that. Okay, and that's important, because if they're that frustrated and they know I can't do all that, I cannot spend that much money, it could be that they might unfortunately go the extraction route. That is why the treatment plan the restorative plan determines a lot of the patient's decision as well. All right, again, a systematic approach. What are some of the etiology agents in endodental caries? Lesions, swelling, microleakage, is there sinus tract, trauma, cracks, and non-healing of previous endo treatment. All right, so the phase one is always emergency. So endodontic treatment, by default, a lot of the diagnoses come in the emergency treatment, because a lot of the endo pain presents as an emergency, especially the necrotic pulp with acute apical abscess and symptomatic apical periodontitis. Both of them can be very painful. Once you do an emergency treatment to the patient, you move towards the disease control, okay, which is the etiology. The phase two is your definitive phase, restoration and reconstruction, and then the follow-up or the maintenance. You want to know your treatment, your treatment you provided responded in a favorable way. How do you know that? Because when you call the patients for follow-up in 3 months or 6 months, then you know that the patient's asymptomatic and there's start of an evidence of radiographic healing. Okay, so there's more bone filling in osseous integration. Okay. All right. Treatment planning considerations, diagnosis, the endoperiodontal status. So remember, I told you initially that the endodontic prognosis depends on the endoperio status as well as the restorative status. Is it restorable or not? Is it already grade 2 mobility with significant bone loss? Then you know the periodontal attachment is compromised. Should you do endo? Should you do extraction? Okay. Resorption. So we saw in that case, right? That's important. If you take your angle radiographs, you see it's very extensive, like the tooth was blown out pretty much. Then you're thinking that your option is going to be extraction. Radiographs, good diagnostic quality, procedural difficulties, all right? Physical limitations of the patient cannot be suitably inclined. That's important because it's going to determine whether it's going to be a referral. So, you're not used to doing a second or a first molar standing. Especially the patient cannot be reclined. So that's a case for, in terms of the complexity, the physical limitation is a referral to the resident. Restorative considerations, severe caries, fractures, and so. Anatomy. If it's a complicated anatomy, that's a big one, right? So the ones where you have those S-shaped curves we talked about in the endo-sophomore lab, C-shaped canals, or if you have extra roots or you have dilacerations, they're automatic referrals to your specialist. Okay? Treatment options for the diseased tooth. Some of the questions: what are the alternative options to this endo treatment? What is a dental implant? That's a question the patient may be. Some patients know, some patients have heard it, but they don't really understand it. So be ready to answer these questions, because the patient can ask that. They can say, well, what if I don't want to do retreatment at all today? Tell me about this implant. Okay, so be ready to have that dialogue. finances involved, the procedure that it involves is a surgical procedure. What is involved in placing an implant? Are there any other options I have? Who performs this procedure? And that's important because sometimes you tell the patient in the first appointment, okay, do the caries control, you build the wall up, you know it needs crown lengthening, you're ready to do endo. You inform the patient about the crown lengthening, but you don't inform them enough. Because sometimes we've had patients who are just like, wait a minute. So at the end of the procedure, you're like, well, now I'm going to schedule you with the periodontist to do crown lengthening. So then they're taken by surprise. They're like, wait a minute, so you're not going to do the crown lengthening? I thought it's a part of the procedure. So that's important to share with them that who performs the procedure? The root canal is performed by you. However, you're going to refer it to the periodontist to do the crown lengthening procedure. And then your general dentist for the restorative aspect. To know who's performing these procedures, so they need to be prepared that they're going to be going to different places with different aspects for this one. Okay? How do I make a choice? Help them. Explain to them the prognosis, explain to them the pros versus the cons for these, the risks, the benefits for each treatment option. So let's talk about this prognosis because the patients are going to ask you, well, you're asking me to retreat it. What's the guarantee now it's going to work, right? It's a very fair question, right? So I tell them, I said, well, first I can see that there is an unobturated space. I would like to address that. And most of the literature right now, the most current evidence talks about now we have better techniques. We have microscopes we use, more ultrasonics we use, better materials. So we have a better prognosis for this case. The retreatment success is 81%, and some of these studies now coming up, it's as high as 89%. So that's a pretty high percentage. You go to endodontic surgery, 95% success rate. That's a pretty good prognosis, as opposed to 40%, which was many years back when we had traditional surgery. But now with all this armamentarium and technology, it's skyrocketed to 90 to 95%. That's a pretty good deal. The patients are like, oh, well, I'll try that, if it's going to save my natural tooth. Extraction and replacement using a single tooth implant, 95% success. Extraction replacement using a fixed dental prosthesis, 10-year survival, but it goes down within a 15-year survival, down to 69%. Intentional replantation, 87%. What is intentional replantation? Intentional replantation is where you actually extract the tooth. You do the endodontic surgery outside the mouth in a well-controlled media and then implant it back into the socket. That sounds a little crazy, doesn't it? But actually it's got a very high success rate, 87 to 90%. Okay? Extraction without replacement, do nothing. So obviously that will always be, but typically your treatment options present with your prognosis right next to it. So be able to tell the patient confidently there's a pretty high success rate. And now with the CBCT, integrating a 3D imaging technology, you can directly get to the root. Okay? All right, retreatment versus root and surgery. What do you think about? So when you're thinking about, should I do retreatment, should I do root and surgery? There are a few things that help you make that decision. Okay? The first is the quality. So we saw in some cases that there's just a missing obturation in the entire canal. So there's a compromise in the quality. Coronal leakage, are the crowns leaking? Because then you'll benefit from a retreat because you're going to replace the crown anyway. You might as well retreat it over there, which is causing symptoms. Restoration to be replaced, possible etiologic factor that could be corrected by retreatment. Proximity of the anatomic landmarks and extra-radicular infection. Okay? A tooth may not heal as expected after initial treatment, or a new problem may arise. A variety of reasons for a tooth. It could be a narrow canal. Maybe you didn't get negotiated. As you know, in endodontics, what are some of the technical errors that can happen? Ledging, right? Blocking, separating an instrument, perforation. So if that happens, so you look at a canal, you notice it's short. Maybe somebody was not able to negotiate all the way down to the apex. Complicated canal and anatomy went undetected. So maybe you just missed the entire MB2, or you couldn't get through the S-shaped curve. The placement of the crown was delayed following the endo treatment. That's a big one. So sometimes I ask the patient, do you remember when you got the crown? And then they might say, oh, my temporary was on for a year, and I just really couldn't get to it for finances, and now I have the crown. So there was a reason why there was contamination, because the patient delayed a temporary restoration for a year, and temporaries usually leak within 30 days to almost 60 days. The restoration did not prevent salivary contamination. A new problem may arise. New decay can expose the root canal filling. A loose, crack, or broken crown of filling can expose the tooth to new infection. A tooth sustains a fracture. So a case like this, if you have a broken down tooth, you have a fracture, it's a big crack heading all the way down to the CEJ, then that might be an extraction followed by replacement prosthesis. Okay? All right, so a case like this, as you can see, good amount of space that was not negotiated. So you go back, and when there's another case, you see the root canal's done well, but there's micro leakage, open margins that cause contamination. In both these cases, like in this case, the crown was replaced, I would highly advise to do a retreatment. In this case, I would be like, well, I would do a surgery or a retreatment. If the patient says, I don't want to disassemble the units, I'd probably do the surgical route. Okay. All right, so cases like this, believe it or not, many years you can see things like this happen, and you might be looking at a retreatment and a surgery. And I tell the patient, I might be doing both of them because I may not be able to retrieve that at one. If I can at one go pull it out, awesome. If I cannot, I might have to go surgically to remove this. Okay. Similarly here, a missed canal. You open it up, look under the microscope, and this entire canal was missed on this premolar. Only one of the buccal canals was filled. Okay. An apicoectomy. So what is an apical surgery? So you'll learn more of this in the senior advanced course. Okay? It's occasionally needed when inflammation or infection persists in the bony area around the end of your tooth after a root canal procedure. Microsurgical endodontics is now the new way to do endodontics surgical procedures, so it has a very high success rate. Use microscopes and ultrasonics in conjunction with each other. So as I mentioned to you earlier, these are really good numbers. As you can see, traditional, many years back, it was 44 to 57%, but now contemporary microsurgical endodontic procedures have skyrocketed the success rate to 95%. Okay? All right, so as you can see here, we've raised the flap. So it's like a surgical procedure. We raise the flap, expose the tooth, we'll do an osteotomy, expose the root, resect it 3 millimeters, and then fill a biocompatible material. So you see this white? You're seeing actually the other side of magnification of directly into the apex. And as you can see here, this is that white biocompatible material in the long axis of the root. And then we close it up with sutures, and then you can see within a year or 2 years is complete bony regeneration. Okay. So a nice case like this. So you see something like that, that's probably amalgam. So in traditional, many years back, they would actually compact amalgam in the surgical procedures. And then you can see that they have a high risk of cracks just because of the amount of forces. But now with microsurgical endodontics, you can see we have a small area that we prepare with ultrasonics, clean it out, and put a biocompatible material. So this, again, is an example of a very good case. You can see how it started. You see a big lesion like that, and you wonder if surgery works, and it does. So we resected with the material, fast forward a year, and you can see complete healing. So absolutely, endodontic surgical procedure should be in your treatment option. And when in doubt, consult with your faculty if this is a case that can require endodontic surgery or not. So for example, if it's a second one, mandibular molar, with the same scenario, with a big lesion, root canal already done, retreatment is not really an option for the patient, then yes, absolutely, you can consider doing maybe intentional replant because a second molar, lower mandibular molar, is sitting right close to the mandibular canal. You want to be a little cautious because they have a high risk of paresthesia. In that case, then you may choose intentional replantation because you can extract it, do the surgery outside, and implant it into the socket. So microscopes, along with our microsurgical instruments, we can cut a nice clean window. So one tooth over and one on either side of it, and then raise the flap, and then resect the root, create an osteotomy in the bone, expose the root, resect it, fill a biocompatible material, and then suture it back on. Okay? So, and this can completely heal and fill up with healthy bone. Sometimes the tooth cannot be saved, and the alternative is only extraction, and that happens, and that's okay. So if you see a resorption that's completely eating away the root, or you see a fracture, or you see a crack that goes all the way down to the percation, you might be looking at an extraction followed by replacement process. So what are these replacement processes to your patient? You can talk about dental implant, or bridge, or a removable partial denture, depending upon what the case presents. Okay? Factors which influence the patient's treatment decisions: professional factors, patient factors, and combinations. So one could be just the patient's behavior patterns on, I don't want to do this, I just want to go extraction. One could be the finances, one could be the time, because these procedures require time. They cannot be just done in one sitting, quick and go. Sometimes patients are not ready to invest in that. Diagnosis, reasonable treatment options, risks and benefits for all patient procedures must be explained to the patient, and the costs of the treatment. That immediately decides for the patient if they want to proceed to the therapy. Importance of maintaining an open dialogue with the patient. What happens if you want to be have a really good communication with the patient? So I like to, as I'm talking to them about the case, I'm looking at the radiographs with them, I'm making them a part of this treatment, not just an information piece, but also a part of it. So I show them the healthy area on the radiographs. I show them their tooth, and I see why this lesion is there. Why do you have this full coverage crown? Why is it leaking? I make them a part of my discussion. Patients are less anxious and recover with fewer complications if you have a good open communication throughout. Patients who share early on concerns and questions are likely to contact the dentist, and are less likely, to contact the dentist later on, because again, they shared their concerns, they understood the procedure, and you've answered whatever you could possibly do, including the financial part of it. And don't forget, with the finance and the procedure, you're also talking about time. Okay, so don't say that, you come in next, we'll start the retreatment, it'll be done. You're at least looking at 2 or 3 sittings, not to mention the crown, which goes on top of it, and so forth. So be realistic, because depending on their professional commitments and their work, they may not be able to invest that much time. Patients who are well informed of what to expect are more willing to tolerate the discomfort. So let them know if this is going to be post-op pain, and if you're giving an emergency treatment, expect to have some discomfort, and then treatment and will continue. Because if you inform them about the pain, they're less likely to get alarmed or share with you discomfort. So, I have patients where we tell them about flare-ups. So, patients who come in with pain have a higher chance in studies to have pain in between appointments. So I tell them if that happens, we'll give you a combination flexible analgesic therapy, not to be alarmed. Inflammation does happen in between appointments as well as we move towards the healing stage. Okay, so the patients don't panic and say, well, why am I having pain still? Explain to them that it's a process. We're cleaning out the infection, we're putting medication. We might have to replace the medication until we get to the point where you're going to asymptomatic. Okay? So just another example of tracing sinus tracts, very important to be able to establish if it's a perio or a perio-endo problem. Okay? So this is an interesting case that you looked at. If you look at it here, you see the post is clearly not within the guides. It's not within the canal, it's not half in bone. In fact, if you took this radiograph, it's a little misleading, but you take a bite wing and you notice there's a perforation. No wonder the patient was in a lot of pain to biting, because over here it doesn't really look like a perforation. I do see something, but I'm not convinced. And I take a bite wing and I see it straight out the furcation area. Okay? So again, take good quality radiographs, but could you be missing the entire treatment plan on this, or not an adequate, accurate treatment plan? Identify complex cases. So look at the anatomy, look at the PA, look at severe canal calcifications, curvatures, difficult access. Sometimes it might just be that taking radiographs on the patient is a problem. So again, that's important. So if you find that to be an issue, because with endo, radiographs are critical throughout monitoring the procedure. Limited mouth openings, the patient cannot open, and you're thinking of doing a first molar or premolar also. You might consider referral to an endodontist. Difficult patient management, complicated retreatments, cause requiring surgical treatment, large periapical lesions requiring biopsy. Okay, so all these cases are moving towards complexity as you go down the list, and you think about referrals. Okay? Case like this, again, you can see that the root canal is not done adequately. You can see the tapers are inconsistent, there's voids. So I'm not too happy with this. Same here, look at this. Doesn't really look on the premolar that's adequately instrumented and obturated. Similarly with the molar. So you see a case like this, you're thinking about presenting to the patient the treatment plan to be retreatment. Okay? Again, a case like this. this is a no-brainer, right? You look at it, you're like, wait, they didn't even fill the canal. And over here, it looks like they just barely put one gutta percha, and that doesn't even look like it has sealer in there. Okay, so you might want to think about retreatment in this case when you present a case. All right, so this is another complicated case. There are a lot of complications in this. Not only do you have to drill the full coverage crown, you have gutta percha out the apex. Then you have a broken disarticulated instrument. You have another broken instrument. And you have another broken instrument post. Don't know what that is now, right? So you have a lot of complicating factors in this. And I let the patient know that this is going to be a complex case. We are dealing with a lot of disassembling a lot of these radiopaque materials in the canal, and that could take 2 to 3 appointments. So I tell them realistically, I would love to be done in 1 appointment. It looks like, given the complexity, I might take 2 to 3 appointments. And I also explain to them that if I cannot get through all of them, I might have to consider doing a surgical approach. Okay? Okay. All right. All right. This is immediate post-op, as you can see here. Okay, so we had cleaned it out. We removed all the instruments, all the disarticulated instruments. As you can see, the lesion has already started healing. So let's go back. You see that big radiolucency go in the front. It's completely healed. It's healing. Sorry, this is 1 year. So I will continue to follow up in about 1 year, 2 years, 3 years until there's complete resolution. Okay. All right, another big case. As you can see, look at the post. It's not adequately within the guides of being half and bone. Look at the filling. That's also below quality. Look at this. I barely see anything in there. It looks like a sealer. Okay, so cases like this, we went back, retreated it, and then you can see this resolution of that periapical. Okay, so what's important to show you in this is also the fact that you see something like this, the patient's symptomatic, don't be in a rush to extract it. Retreatments are very successful, and so are endodontic surgical procedures. So you have multiple options to save that through. So always make sure you have that dialogue with the patient. Okay, all right, a complicated case with 6 canals, right? You can refer to a postgrad, but you can save it. All right, obturated. All right, so another case, as you can see here, the patient did not want us to disrupt that post, even though it wasn't deep. They were just like, I don't want you to touch my crown. I'm not paying for this because I have all crowns everywhere and I'm not doing it. Okay, well, I respect that. We can do the surgery because you definitely have a lesion and we need to address it. And it's getting bigger, so it might compromise the tooth. Okay, so in this case, I might consider resection. So you can see it's blunted because we did an apicoectomy. So we did an endodontic surgery. We filled a biocompatible material in there. Okay, and as you can see, it started healing already. Okay, 1 year. So that was how it was immediately post-op. And then on this left side, complete healing. So these cases heal, guys. So think about that for a minute, okay? So you definitely know that retreatment and surgery are in positive lights, given the fact that now we're in an era where we have very good armamentarium and technology to address this, okay? So I'm going to give you guys about a few minutes to ask any questions, because what I'd like to do is I'd like to move to the cracks and vertical root fractures. I'm going to post it up, but I do want to just talk about the differentiation of how do you differentiate a crack versus a vertical root fracture. Okay, so let me see. Got a question here. For those of us who didn't have a block, will we still have it? Wait, what? What block is this? Who didn't have a block? Oh, I see. Oh, that's a very good question. Thank you for reminding me. So I think that I'll have to see how many were there, but maybe we can talk to the Endo faculty and see if I could create maybe a video of some sort that I could share with you. It's very easy to do. You know what I'm going to do? What's the best way? Maybe I'm going to schedule a synchronous presentation where I can do a live navigation of Axiom. That might be the best way to reach to everybody. Okay? So maybe I will try to see if I can schedule with you guys. I'll work with Dana Jones and see which is a good time to schedule for a synchronous lecture like this. Does that sound good? And then I can take my Axiom and show you how to fill in data. Okay? Thank you for reminding me, by the way. I've forgotten about that. All right, any questions on the lecture today? If a patient would ask, what is the difference in price, time, and recovery between retreatment and SLEUTH? Very good question. So the question is, I'm going to repeat it to the class. If a patient would ask, what is the difference in price, time, and recovery between retreatment or surgical procedures? The first difference is, and that's a valid question. So I would tell them the price difference between the two is not too much, believe it or not. So retreatment might be up to, of course, now we have reduced prices in the school given the pandemic. But retreatment says if that's like about close to $1,000 or $900, a surgery would probably be $1,000, $1,200, something like that. I have to look up at the recent prices, but typically that. But in terms of time, surgery is a one-step appointment. A retreatment can be 2, even 3, because as you saw in some of these challenging cases, I never tell the patient that, I'll be done in 1 appointment. I always tell them be ready for 2 appointments, even 3, and they're ready to do that because they'll do anything to save that too. What's the recovery time? With a surgery, like any other surgery, it takes about a week to completely heal. But typically within a day or two, the patient starts having resolution of symptoms. But there's a healing phase within a week. And typically with a retreatment, it takes them about a week or so for complete resolution of symptoms as well. So recovery time is almost equivalent for both. Can you clarify what you mean by, so I hope I answered the question. So the time is different. It's a 1 sitting for a surgery and 2, maybe 3 sittings for a retreatment. The price is a little different, but not terribly different, depends upon, because if the retreatment involves replacement of the full coverage crown, it's going to be probably equivalent to surgery. Does that make sense? Let's say the retreatment is say like $700 or $800, the crown is $400. That comes close to what the surgery is. So it all depends upon what's the additional aspect to doing that retreatment. Okay? If you can clearly see the canal outline through a root resorption lesion in a straight-on radiograph, with how much confidence can you assume it is external? So let me tell, that's a very good question. So the question I'm going to repeat again. If you can clearly see the canal outline through a root resorption, which means it's internal root resorption, how much confidence you can assume it is external? The answer is I don't have confidence until I take my angle radiographs. So even if it's a straight-on view and you think, I can see the canal, I don't know. Remember, by default in endo diagnosis, you must take a mesial shift and a distal shift. Okay, because if I'm in any doubt, if I'm like, I think it's internal, that would solve my answer. So don't present any resorptive case without a mesial or a different angle radiograph, okay? Okay, thank you, that answers my question. All right, guys and girls, so I'm going to switch the screen to cracks and vertical root fractures. We don't have too much time, but you can read through it, but I want to just point out some key differences between the two. Okay? So if you just give me a minute, I'm going to stop sharing it and then move on to sharing the screen with the vertical root. That is right. I'm trying to see why. All right, this one. All right, so hold on. All right, hold on. Where my head is supposed to be? Okay. All right, guys. So I'm going to talk a little bit about cracks and vertical root fractures. Okay. So this is an important one because you will inadvertently end up encountering this at some point, whether in an emergency treatment or not. Okay. So vertical root fracture. What is the main difference between cracks and vertical root fractures? Just look at the terminology. Cracks are mainly in the crowns. Vertical root fracture. So it's always in the root. So if you look up these images up here, it's the root. And the vertical root fractures are hidden because they're covered by the gingival tissue, overlying gingiva. So it's very difficult to diagnose a vertical root fracture. Cracks, however, are in the crown, so it's easier to diagnose. Okay? Cracks can be defined as crazed lines, or when the patient they present to you in emergency clinics and you look at it, the entire cusp has been fractured off because they bit into something or there was some trauma. Cracked tooth and then split tooth. Sometimes worst case scenarios, you'll have a bad traumatic accident and the patient presents and they literally, when you put that probe, it splits and they're in terrible pain. In that case, it's an extraction followed by replacement procedure. Okay? Fracture always begins apically and extends, so it's the entire circumference of the root. So if you look here, it starts moving up. But typically, if you have vertical root fracture, it's an unfavorable prognosis. Okay? All right, so crack through tooth from monomarker filling. All right, so if you see here, it's a through and through crack. So what's the difference between a crack and a vertical root fracture apart from the location? Cracks are in the crown, vertical root fractures are in the root, and they're hidden in bone. Cracks run in a mesiodistal direction. See here? Mesiodistal direction with the cursor. Mesiodistal direction. But the fractures, vertical root fractures, run in a buccolingual plane in the root. Okay? You can only determine the extent of the crack if you remove the complete restoration and look under a microscope. So you have to, if you see something like this, so if you look at this up premolar with the arrow, you see a crack in the mesiodistal direction. Don't just look at a crack and you diagnose it with a tooth, the patient jumps on the cusp when you bite on it. Okay, so you know it's a crack and it's symptomatic apical periodontitis, given whatever the pulpal status. But you don't look at it and you just say your treatment plan, okay, let's extract it. Okay? Because it's not always the answer. You can very well save these cracks. The first thing you do is you have to remove the entire restoration, be able to trace the crack. Okay, numb the patient up and start drilling because you want to get to the point where you can completely remove the entire crack to see how deep it runs. And if it keeps going on all the way down to the pulp or the floor or the roof of the pulp chamber and is still extending, I let the patient know before I start that I'm going to go ahead and diagnose and explore how deep this crack runs so I can determine a plan for you. And if it runs all the way down to the roof of the pulp chamber, then that's an extraction. That's a root canal followed by a full coverage crown. But if the crack goes deeper and deeper into the orifice all the way through the furcation area, then that's going to be an extraction. So it's important not only to recognize the crack, but also how deep it runs. Okay? All right, in posterior teeth, these are crazed lines. I don't want to spend too much time, we can read that. This is a fractured cusp, this is a crack going deep, and this is a split tooth where it involves the crown and the roots. It's kind of like almost split open. Okay? Cracks can be complete or they can be halfway down, incomplete. Pain on biting. So how do you know? The patient, you bite on the tooth, you release and the patient feels a sudden jolt of pain. That's a classical sign of a crack. The vitality test doesn't really help you because you do the test and the patient's responding normal. So that's why the crack is a finding. But your diagnosis might be still normal, cold and APT, so normal pulp with a normal or symptomatic apical periodontitis if it's sensitive to biting. Tooth often has an extensive intracornal restoration. That's not surprising. Patients who have cracks typically have habits, firstly. If you go into the dental history, they'll tell you, oh, I have a habit of, clenching and grinding. Or the other thing is that the patients might say that, it's a crack because the patients have large MOD restorations or an extensive OM restoration with amalgam. Okay, making a diagnosis, dental history is critical. Clinical examination, if you have an isolated defect, if you probe around the tooth and you notice everything is within 2 to 3 millimeters and then all of a sudden you drop, the probe just drops 8 millimeters or 7 or 9 millimeters beyond normal, and everything else around the tooth is healthy, that's a high indication of a crack or a fracture. Transillumination and stain. Cracks are not often visible without the aid of magnifying loupes, tooth SLEUTH, removing restoration. So all these things are necessary for diagnosis. So I let the patient know that even though I'm doing a diagnostic workup, it could be that I might have to open this tooth up today because I need to diagnose further if this is a tooth that can be saved or not. Because I see a crack, but I need to investigate how deep it goes, because that will determine if it's restorable or not. Okay. So that's a tooth SLEUTH. You can see that little cavity in there, and I place it onto the cusp tip, one cusp at a time. So I place it on the buccal, I place it on the lingual, and then I ask the patient to bite, and they feel that sudden jolt in pain. Okay? I know it's probably a crack. All right, so ask the patient to bite on it. Transillumination, fracture seen through that illumination. So you see that if there's a crack, it kind of blocks the light. Okay? You could even stain it, right? Stains it out, and you can see that little crack extending. This is almost a mesodistal as well as almost a buccal. It's a pretty broken down tooth. Factors as predictors: age, endotreatment, parafunctional habits. Okay, so the question here, I'm going to take a step back, is how do you read the stain results? So that's a good question. So that's methylene blue stain that we get even here in the endo clinic. So you stain it, you can take a cotton pellet, stain that tooth, and inside the chamber as well. So if I were to stain inside the chamber, wait a few seconds. You don't need to wait long, just 5 to 10 seconds. Irrigate it with saline, right? And if it's open with rubber dam isolation, you can even use hypochlorite. And then you notice that if it's a crack, the stain will catch it. Okay, so the only area where the crack is, you'll see the stain. Everywhere else is cleaned out. Okay, so that confirms that there is a crack, and it will nicely, distinctly delineate the crack. Okay, all right. So I think in this case particularly, I wanted to bring it up because I think in this, on the top left corner panorama, I think in this case it was interesting because the patient had a severe problem with parafunctional habits, and he kept developing pain and discomfort, and to the point where he developed multiple cracks. And actually, this should have been traced back to managing his parafunctional habit more than anything. You can imagine extensive loss and misplanning of this case and how many teeth he's lost just on this habit that caused severe syndrome of formation of cracks. Okay, so again, you can see here, like I'm seeing a crack, and I see a little bit of the amalgam restoration, and I see this little crack, but I don't know how deep it runs. So you have to go ahead, numb the patient up, put a rubber dam on it, remove this entire amalgam restoration, keep running the burr until you can get the crack to disappear. And if you hit the pulp, then you have to do a debridement at that appointment. Okay. All right. So again, bite test, periodontal probing, isolated defect, all of them are high indications. Right? So major problems with cracks, bacterial contamination, right? Any crack is what? A breach in the integrity. That happens, there can be contamination. Okay? Fractured cusp. All right, so you can see it's a pretty bad case, right? It's almost a split tooth. So in these cases, it's not restorable. So for the pulpal debridement, I think it's 3221, I'm not sure. But those codes can be found in Axiom. Okay, but if you type it on the search pulpal debridement and pull it up, it's D3221. Okay. Complete removal of the restoration will reveal the cracks. So you see here, I see something here, and I see something here, I'm not sure, I keep drilling. And now I can start seeing that crack is well defining. I keep drilling until I see disappearance of the crack. Prognosis, diagnosis determines treatment. Treatment alternatives are important. Patients' questions must be answered. Prognosis is more variable with cracks than longitudinal fractures. And I let the patient know. Typically, even when I do, the crack goes to the roof of the pulp chamber, I tell them, okay, you need a root canal therapy with a full coverage crown. I still tell the patient that, you know what, it's going to be a questionable prognosis unless and until my follow-ups in 1 year, 2 years, 5 years shows favorable. So be realistic about the prognosis. Don't say, oh, it's going to be so favorable because I found the crack now and I can, no. I'm very realistic with them and say, whatever it is, it's a breach in the integrity. We're going to try to attempt to do this. And we're hoping to move towards a favorable prognosis, and we will monitor you in that process, 6 months to 5 years. Okay. All right. Prognosis declines from questionable to unfavorable when cracks involve the below. This was a nice study where they looked at every level of the crack. So they said if it's one marginal ridge limited to the crown, it's a better prognosis. 2 marginal ridges, okay. 1 or more marginal ridge and floor of the cavity preparation, okay. 1 or more marginal ridges extending into a canal orifice, that's a danger sign. That's more into unfavorable because it's going into the orifice. Forget that it's going up to the roof. 1 or more marginal ridges on the pulpal floor. Percussion involvement, okay? All right, so this was a nice table, but I'm going to move to, this is a nice table put off by Dr. Krell. It's really a nice table for you to remember, chair side. But what happens if the patient comes with a small crack? Just remove it, place it with a full coverage restoration. If it's a large crack, see how far it goes. If it's no pulp involvement, stabilize it with an orthodontic band and a crown. If it's pulpally involved, do your stabilization of the crown and pulp extirpation. Monitor the symptoms, complete endo treatment, and a full cuspal coverage crown. If it's really bad, extends all the way down, poor crown to root ratio, then it's extract. Okay. All right, so I'm just going to go fast forward to vertical root fractures. All right, it's diagnosed years after the tooth, so they always call it like a silent killer, right? Because you can't really see it on a radiograph unless it's really extensive, like we just saw. And it's also because it's confusing. Sometimes you see a lesion and then you're like, is this a failing endo or is it a fracture? Both of them can have periapical and lateral radiolucencies. Of course, if you see something like this on a radiograph, it's easy because then you're like, oh, well, this is a vertical root fracture. However, a vertical root fracture is the cause. It's an etiology of finding. It's not your diagnosis. Diagnosis would be previously treated with asymptomatic apical periodontitis. Okay? All right. Vertical root fractures, just like cracks, can be completely the entire root or partial. Okay? All right. Vertical root fractures mimic other conditions. They're not diagnoses, they're findings. And that's what I said. You must have a diagnosis. All right, so I want to explain to you a little bit about this study. So this looked at the impact of operative procedures on vertical root fractures. So they found that the most important cause, like we saw parafunctional habits, large intracoronal restorations for cracks. What about vertical root fractures? They actually found that a lot of clinician errors can cause vertical root fractures. For example, using too many forces during lateral compaction, drilling a post with all the forces in there and predisposed to a fracture. 61% of teeth had a post present. 4 types of posts were associated with vertical root fractures: screw posts, amalgam cores extending. A full crown was observed in 76% of these cases. What does that mean? Be cautious. Not all endo-treated cases need a post. And sometimes the way you stick a post in there can predispose it later on to a vertical root fracture. You look back, 2 main iatrogenic factors have been demonstrated to be a cause for vertical root fracture. One is post placement, the other one is excessive compaction forces during root canal obturation. Holcomb in a study said, well, what do you mean by excessive compaction? We all use our lateral spreaders to create space for our accessory cones. So this study found that pressure of 16 kg is actually needed to cause a root fracture. In a clinical situation, we don't go more than 3. Okay? So really, the post that you place can be also significantly associated with a vertical root fracture. Okay, diagnostic clues: an isolated deep pocket and a J-shaped lesion. What's a J-shaped lesion? It's a periapical and a lateral radiolucency. Okay, so you can look at this in your own case, but I want to show you. See that periapical radiolucency? Along with that, it's wrapping laterally as well. Okay? Isolated pocket. See that probe? It drops right in the entire length of that tooth. That should be a sign, okay, there's something going on, either it's a crack or a vertical root fracture. On another interesting part about vertical root fracture, it's commonly associated with teeth that have endo treatment. Okay, because why? It's associated with post and root canal obturations. Okay? When you have 2 sinus tracts associated with an endo-treated case, it's almost pathognomonic. presence of 2 sinus tracts. So don't forget, people, to look at your lingual and your palatal. It's typical you look at the buccal and you say, okay, I have a sinus tract. I'll take a minute to dry the gauze and look in the palatal and the lingual. If you have 2 sinus tracts, you're probably looking at a vertical root fracture. Of course, take a radiograph, do your periodontal probe. Okay? The teeth most commonly associated: maxillary second premolars, mandibular molars, and so forth. A vertical fracture along the buccal aspect of the root identified upon elevation of the flap. As you can see here, you can see this small little periapical and lateral radiolucency, and you can trace this sinus tract. Okay, so sinus tracts are commonly seen. If you reflect it back, we did a surgery and see that fracture. Okay, another case. See that? You have a root canal treated case. You trace the sinus tract. We wanted to completely confirm. We did an exploratory surgery, and you see the fracture running the entire. Okay. Just to show you different patterns of bone resorption associated in studies with vertical root fracture. You can see fenestrations, you can see dehiscences. It's not uncommon with vertical root fractures. Okay? All right. Digital radiography: can a periapical radiograph diagnose vertical root fracture? Chances are low. But a CBCT, regardless, we are still looking at a 2D view of a 3D structure. So vertical root fractures are not always easily discernible on PDAs. That's why it's a difficult diagnosis even in today's day and age. CBCT has helped in every other aspect in endo, but however, diagnosis, it may have moved to 15 or 20% periapical diagnosis with a digital radiography to 40%, but not more. Okay? Which means that 60% of the CBCTs cannot diagnose a vertical root fracture. Okay? So pre-op assessment, root morphology, dental pathosis, root fractures, resorptions, perforations, retreatment, calcified cases, all of them require a CBCT, but a fracture is still hard to diagnose. It can diagnose missed canals, the CBCT, as you can see here on an axial view. Root number 2, you can see a vertical root fracture on an axial view, right? You can see a big PRL, again a lateral radiolucency creeping up. Another, look at that distinct periapical lateral radiolucency. It has a root canal in it. It's the mandibular molar. Remember, the mesial root of mandibular molars and premolars are commonly associated. You take a radiograph, right? You flap it, and then you see the fracture. Okay? Right, so I'm going to move on to some studies. So really this one. So the ability of CBC to detect vertical root fracture in endodontic and non-endodontic treated teeth in 3 reported cases, out of which only 1 could be diagnosed. Detection of vertical root fractures in endo-treated teeth by a CBCT scan. A CBCT can detect it twice as many teeth as PDA radiographs, but not all of them. Okay, so it doesn't mean that if you take a CBCT 100%, you're going to diagnose it. It's a step better, but the 100% diagnosis probably by doing an exploratory surgery, by directly flapping it, looking directly under the microscope. Okay. Fayad in 2012 looked at 5 findings specific for a vertical root fracture. He said loss of bone, absence of the entire buccal plate, radiolucency around a root where a post terminates, space between the buccal and the lingual plate of the bone, and visualization of the vertical root fracture on the CBCT could be good indications of a vertical root. Okay. It was a quick synopsis, but I thought it would be nice if I explained that to you. So cracks are more on the crown. Vertical root fractures are seen more with endo-treated cases with the post, and also the cracks run in the mesiodistal direction. Vertical root fractures run in a buccal plane. The way to diagnose cracks, you can still diagnose direct vision by removing the restoration, looking under the microscope. Vertical root fractures, we have to do an invasive procedure, which is a surgery and a CBCT. Okay. Any questions? Okay. All right. So let me see if I have a minute just to switch screens here. I was going to go to, okay, so I was going to go to your Blackboard again, and I was going to show you that if you go under course documents, okay, and you go under August synchronous lectures, you can see in the first thing that we covered today, diagnosis and treatment planning, 5-3 diagnosis lecture. Then I have the diagnosis of cracks and vertical root fractures that we just try to go over quickly. But I want you to look at this treatment guide. It was posted by the Colleagues of Excellence, the American Association of Endodontic. It's really a wonderful treatment guide for treatment options in endo, and I would highly encourage you to look at this. You might even get some cases in your exam for this, but it's a really great guide of just cases, complicated cases you look at. Like, see something like this. You look at deep caries on this in the pre-op, and then sure enough, on removal of it, it went all the way down. It wasn't a favorable crown root ratio for crown lengthening, and they determined it to be an extraction. Similarly here, you can see, so not everything can be saved, and they give you really good options with the correct terminology in endo: favorable, questionable, unfavorable. It talks about you have a less than 1 millimeter ferrule. It talks to you about specific reasons why. It's a really nice option guide. So a case like this, again, you definitely would think of retreatment, because you can see that it's a big lesion, and you can see that there was no endo treatment done. It's necrotic. Okay, so again, other cases, very nice case of internal root resorption. Again, take your angle radiographs. You can see the canal through here, but you can still repair it with an endo treatment along with a surgical approach to management of this resorptive defect, and it did heal. Okay, so I think there are some really good cases they brought together. Look at this case, internal root resorption, right? See that extent of that. Okay, and this is another interesting case with trauma. As you can see, there was exposure of the pulp. You do a root canal, build up the crown, and then you can see it heals. Okay, horizontal root fracture. Again, you make sure you review the trauma lectures. I would actually, if I were you, I would start reviewing trauma following today's lecture, because trauma is a critical aspect to diagnosis. Okay, the horizontal root fracture, you don't really need to touch the apical segment, do the root canal in the coronal segment to the fracture, and then it heals. Okay. All right, so please look at this guide. I think they did a really good job putting some really interesting cases together for you to think outside the box. And what I really like about it is the way they broke it down to favorable, questionable, and unfavorable. So what would make it questionable today, and what would make it unfavorable? So it also answers a lot of questions that a patient may pose to you. Okay? All right, everybody. So it's Friday, and I'm sure you've had enough of didactic information. So I'm open to asking any questions right now. If not, please, I think let's do this, with a virtual platform. Please start reviewing your lectures. Again, I would review it in order, and one good order would be your diagnosis, followed by trauma. Then you can move a little bit into your non-odontogenic pain, because that's also a part of diagnosis, kind of correlates nicely to what we spoke today about. So, lectures are all available, but try to follow that order. You will understand it a lot better, and it'll be really interesting when you learn all the information on just the diagnostic part. Then move on to local anesthesia, so clinical aspects to care, managing to numb the patient up, and then move on to the other elements like trauma, of course, you've already reviewed, but prognosis, outcomes, then you talk about nitrous oxide, all those things are critical. Leave that towards after your trauma, non-odontogenic, and diagnostic piece. Okay. Well, I enjoyed sharing that with you. So